turn the floor to Dr. Sheena Chu, a leader at Biogen, working to lead many clinical trials, including many that leverage neurofilament as a biomarker. And so the title of the topic, the talk is how to use neurofilament as a tool in ALS clinical trials. So thank you so much for sharing your expertise, Sheena.
All right, well, what an honor to be here, come home and talk to you all about neurofilament and ALS. So my disclosures are I'm an employee of Biogen. So let's just get started. So neurofilament is a cytoskeletal protein that is highly expressed in neurons, especially in axons. And then following axonal injury or neurodegeneration, neurofilaments leak into the interstitial fluid and they can pass into the blood and spinal fluid where they can be measured in people living with disease. So neurofilament is a nonspecific marker of axonal injury neurodegeneration, but it's particularly useful in ALS. So we find that neurofilament levels are elevated in ALS as a group compared to healthy controls. And also these levels exceed levels that are seen in other neurodegenerative diseases like Alzheimer's and Parkinson's, FTD. And we're understanding more and more the natural history of neurofilament in ALS specifically. So what we're understanding is that early on in the disease, when the disease biology begins, even before symptoms start, neurofilament levels rise. And then as the disease manifests, the neurofilament levels stabilize over time. So you can see on the left data from Michael Benatar's PreFAL study where ALS gene carriers have rises in neurofilament right before they develop clinically manifest disease. And on the right, we have some unpublished data from the EMPOWER study of dexpramipexole in ALS. We have 118 people with neurofilament levels over the course of a year. And you can see the spaghetti plot over time. Their neurofilament levels really are stable over the course of the year. So overall, it tells us that neurofilament levels rise early and then stabilize out. What we also understand about neurofilament in ALS is that higher levels of neurofilament are a poor prognostic factor. So they're consistently associated with higher risk of unfavorable outcomes, such as shorter survival. On the left, you can see higher levels of neurofilament are associated with shorter survival, and then also are an independent prognostic factor of faster rate of disability progression. So given what we know about neurofilament in ALS and what's emerging, we have been using neurofilament and are continuing to use neurofilament in 3 specific contexts of use, 3 different ways that we use neurofilament as a biomarker to support ALS clinical trials. And I wanted to share a little bit about our experience using neurofilament in these 3 ways. And the first way is the use of neurofilament as a prognostic biomarker of disease progression and survival, which is what we have the most evidence for, and using that as a way to control for disease heterogeneity in study populations and ensure that treatment groups are balanced in a study. So given how heterogeneous ALS is, we've historically used clinical features such as disease duration or pre-randomization ALS-FRSR slope as inclusion and exclusion criteria, and as covariates analyses to first homogenize clinical trial populations and then also to balance treatment groups in the analysis. But what we've seen in the data from our trials is that neurofilament is a stronger prognostic factor than these baseline clinical features, and that's consistent with what's been being reported in the literature. And so this improved approach that we're moving toward is adding baseline neurofilament as a covariate in the analysis. And this has emerged as a critical strategy for balancing treatment groups and interpreting trial results. And then moving forward in a future state, we would love to see clinical trials where patients are stratified via dynamic randomization using baseline neurofilament, as well as using baseline neurofilament as a covariate along with other prognostic markers for the analyses. And in addition, prediction models are actively being evaluated to see if neurofilament can further improve their prognostic strength. So the second use of neurofilament in clinical trials for ALS is as a biomarker of treatment response, a surrogate biomarker. And I wanted to share a little bit about our assessing for neurofilament lowering as an evidence of treatment effect across the different ALS drug development programs at Biogen. This is the data we're all most familiar with, and this is from the tofersen development program for SOD1 ALS. And in the VALOR phase 3 study of tofersen for SOD1 ALS, we see that treatment with 100 milligrams tofersen robustly reduced neurofilament levels in both the blood on the left and the CSF on the right over the 6-month placebo-controlled study. That was about a 60% reduction from baseline, and this is in green. And the folks who were on placebo originally and received tofersen in the open label extension showed a similar magnitude of neurofilament reduction in the open label extension over a similar time frame. And we took this as evidence of reduction of neurodegeneration. During our interactions with the FDA also noted that there was a temporal relationship between reduction in neurofilament in plasma and then reduction in ALS FRSR decline, which happened afterwards. So there was some agreement that neurofilament reductions happened first, and these preceded and predicted the reductions in clinical decline later on. And I won't go into specifics here, but there was a surrogacy model that was developed. It was to interrogate the relationship between neurofilament lowering early and then clinical outcomes over time. And this surrogacy model was instrumental in the FDA supporting that neurofilament was a biomarker that was reasonably likely to predict clinical benefit in SOD1 ALS. So we took our learnings from tofersen in the SOD1 ALS program to other forms of ALS, including C9 ALS, as well as the broad ALS population. So the BIP78 program was an antisense oligonucleotide against the C9 sense repeat. And in contrast to tofersen, treatment with BIP78 did not reduce neurofilament compared to placebo. So the BIP78 arm, 60 milligrams is in green and the placebo is in the dotted line. The 90 milligrams is in the blue solid line, placebo in the dotted line. In fact, there was some trending toward increases in neurofilament in the treated arm compared to placebo. Similarly, our BIP105 program was the antisense oligonucleotide against ataxin-2 protein for the broad ALS population. Treatment with BIP105 at the highest dose for 6 months didn't reduce neurofilament compared to placebo at all. And the neurofilament data for these two programs, which was supported by a lack of benefit of any clinical outcome in the longer term, even when the analyses were incorporated neurofilament as a covariate, that allowed us to feel confident in our interpretation of the data, even in a short, small study, and feel confident in our decision to terminate the program. And I wanted to highlight that when we make decisions based on a biomarker like neurofilament, or use that as our main decision-making tool, that we don't look at just the median or mean reduction. We interrogate the individual data points, and we have to make sure that it's a biologically plausible response, that there's nothing happening in a subgroup, and that if anything that we see is not due to variability or other factors that we need to consider. So this is unpublished data with individual spaghetti plots of neurofilament over 6 months in the BIP78 program, phase 1-2 study on the left, and then in the tofersen phase 1-2 study on the right. And you can see with BIP78, placebo and 90 milligram, as well as the tofersen placebo arm, there is some variability of neurofilament over time, somewhere between 20 and 30% in either direction. And some outliers here and there, so we have to interrogate the individual data. But when we looked at the tofersen 100 milligram arm in the phase 1-2 study, you could see a consistent effect of the drug in individual participants that aligns with the pharmacokinetic and pharmacodynamic properties of the drug, how long it takes for the drug to knock down SOD1 protein, and then how long it takes after that for neurofilament to start going down. And then you also see a consistency in terms of the temporal course of change that gives you a clinical result that this is actually believable. So there's, in addition to the statistical tests, we interrogate the individual data and make sure that there's biological plausibility of what we're seeing. And I wanted to highlight that the use of neurofilament as a treatment response biomarker in clinical trials is in the context, a very specific context of drugs that have a mechanism of action that's meant to reduce neurodegeneration and would therefore be expected to reduce the release of neurofilament from neurons into blood and spinal fluid. So, for example, you wouldn't expect to use neurofilament as a biomarker for a drug that's intended to increase muscle contraction. But for drugs targeting neurodegeneration specifically, neurofilament can be a useful tool to support clearer decision-making in early phase studies that are small and shorter, and to support efficient drug development by increasing power to detect an effect with smaller sample sizes. So in the Thompson paper from 2022, you could see that the sample size required to detect a similar magnitude effect on ALS-FSR versus neurofilament is smaller, and we had similar findings looking at our internal data. This concept is being brought to the Experts ALS platform trial starting up in the UK, where they'll be screening molecules and then using neurofilament as a potential decision-making tool to move high priority drugs into phase 3 quickly. And finally, the third context of use that we're moving toward is using neurofilament as a susceptibility risk biomarker for developing clinically manifest ALS. So we're using neurofilament to identify at-risk carriers who may potentially develop clinically manifest disease, and using that to design a trial to prevent the onset of disease. I won't go into this in detail, but the design of the ATLAS study, which is to see whether treatment with tofersen prior to the onset of manifest ALS can delay the onset of disease in SOD1 gene carriers, is predicated on keeping an eye on people's individual neurofilament levels over time. So we're screening gene carriers and then watching their neurofilament over time. And if their neurofilament increases above a threshold that was modeled based off of the PreFALS data, then they would be randomized to either treatment with tofersen 100 milligrams or a placebo. And then the primary outcome is whether or not people develop clinically manifest ALS. So this is a sort of a new type of trial that we're really excited to conduct. So where do we go from here? We've done a lot so far, but there's still much left to be understood for us to really integrate neurofilament into the way we practice and into the way that we conduct trials. So first, we have to, as you can see, there is variability in neurofilament over time, and there's lots of different sources of variability, and we need to understand where those sources of variability come from and control for them. So the pre-analytical, analytical, and biological sources of variability. And then in the blue bubble, light blue bubble, we have shown that treatment-driven reductions in neurofilament reasonably likely to predict clinical benefit in the SOD1 ALS population, and we need to validate that this could extend to the broad ALS population, and that would really speed up drug development in ALS if neurofilament could be a surrogate for the broad ALS population. And this really requires an effective drug that can show a treatment effect on neurofilament and a treatment effect on clinical outcomes. Third, we need to establish a certified reference material so that we can consistently compare neurofilament levels across assays. There's many different ways of measuring neurofilament, lots of different machines and companies that are doing it, and it's hard to compare across time and across assays. And so establishing a central reference material so that they can be compared will be critical for interpreting the data across companies, across trials, across clinical practice. And then finally, using neurofilament to enhance prediction models, and then using it as a benchmark to identify other novel markers of disease activity and treatment response to really accelerate how we develop drugs for the ALS population. So that's what we're looking forward to doing with all of you. And so I just wanted to end with a thank you to all the study participants and their families and caregivers and investigators who helped, who as a community, we've developed these data together for us to move forward our understanding of neurofilament ALS. Thank you very much.
Thank you so much. This is such important data, and thank you for sharing some unpublished data as well. I was wondering if you have time for one question before we move to the panel. I know some of our speakers cannot stay for the panel, so maybe if you don't mind, Dr. Chu, I'll ask you a question for you specifically, which is already in the chat. So there's questions about kind of phosphorylation of neurofilaments in ALS. Would you mind commenting on that? Any additional insights in terms of which amino acids may be more prone to phosphorylation, and if you can also comment on intermediate filaments.
Okay, so the phosphorylation, I don't know the answer to that. I'd have to go and ask the experts and come back to you on that answer. And I think the second question was why intermediate filaments rather than light or heavy. That's also a question that I would need to ask our biomarker colleagues about. I think it's really that we've measured neurofilament light and heavy first, and so we know the most about it. I don't know that we have that much data about intermediate. I wonder if it would be similar. What we do know is that across different biofluids, CSF and blood, the levels, like the relative levels, are very, very similar. And across light and heavy, they're also quite similar. So we treat them, interpret them similarly, even though they're not interchangeable across fluids. So that is the best I can do when it comes to intermediates, in that we don't have enough data to use them yet. And then I think there was a question about if neurofilament reflects axonal damage, why do they remain stable over time? Because you would expect them to continue to go up. And the current thinking is that, you know, it reflects a level of, reflects a homeostasis, that there is a level of degeneration, that early on in the disease, there's a lot happening and your body is clearing it to some degree, but it's as the degeneration ramps up, you can see the levels rising. And then as you reach a steady state, you're having axonal degeneration, but you're also clearing it at the same rate. And then you end up with this sort of stable level over time. And so someone who has a high level of neurofilament to begin with continues to have the high level of neurofilament over time.
Wonderful. Thank you so much for taking the questions, and thank you for being here.